Welcome to the Frank Lizzie Show live edition. We're here at SAWC Spring 2025, and today we're diving into a topic that's often the bottleneck in a wound care center, and that's your vascular assessment. So the question is, how do we streamline this important component into a very busy clinic? I am Frank Avales.
And I'm Lizzie. Obviously, I agree with Frank. Clinicians everywhere feel the pressure. That's kind of pun intended, right? We know patients of suspected peripheral arterial disease need those vascular assessments. And there's often huge delays in getting those ABIs and TBIs. So we are so excited to welcome our guest.
Yeah, so today we have Kimberly Rossman. And let me tell you, Kimberly is no stranger to the vascular world. She works for Huntleigh, and she's also the clinical manager for Huntleigh. She actually developed and is working on products to advance diagnostic vascular and also treatment products that can help us. And she has a front row seat to the problems that most clinics have. So Kimberly, thank you.
Thank you so much, Frank and Lizzie. I am so honored to be able to be here with you today. So I appreciate it so much. And you are right, the standard of care for PAD evaluation is so important.
Yeah.
And so in a clinic, so tell us a little bit more about what the problems that we see out there, Kimberly.
So our standard of care for vascular assessments are ankle-brachial index and toe pressures, right? And so people are typically sending those patients to the vascular labs, and the vascular labs are overwhelmed. There are so many people trying to get into the vascular labs. So the wait times are 4 to 8 weeks sometimes, and that is just delaying care.
What did we say? Time is tissue, right?
Time is tissue.
Yeah.
Right. And you know, I've been in a rural area, but I've also been in the bigger cities. And I thought the bigger cities would have this problem solved, but you're right, they don't. There's a lot of waiting time. So there's a lot of waiting time.
And even in the bigger cities, it's the problem of the transportation and all the patient-centric things that we may not think about. Like, how is the patient getting there? Like, you already have the patient in your clinic. So let's talk about get her done, right?
What can we do at the point of care to get those values and that critical information that you need to make those decisions for compression, debridement, placing your camps and your grafts. I mean, you need to have that point of care assessment done, and waiting 4 to 8 weeks is tissue. People are losing toes in that time that they're waiting for vascular lab appointments. And so what can we do to make this easier for clinics and more cost effective for them to do their ankle-brachial index or ABIs and TBIs right there at point of care?
So let's speak to the audience as if they've never seen an ABI or a TBI. Like, I'm sure that can seem intimidating if they've never had the training in it. So can you just like walk us through the steps of what like the automated ABI system looks like and how a clinician can integrate that into their practice?
Okay, so let's talk about a manual ABI and what it actually is, and then why we can automate it so that it just can make it faster. So a manual ABI is when you take a systolic pressure of both arms and you compare that pressure, and it's like a blood pressure. If say you're doing a manual blood pressure to the systolic, and getting your systolic values from your arms, and then you're comparing that to the systolic value of your ankles, and you're doing two measurements at your ankles. You're measuring for the dorsal pedis pulse, and you're also measuring for the posterior tib pulse. So you're doing that pumping mechanism twice to get those two measurements, and then you're taking the higher of the two and the higher of the two arms, and then the higher of the dorsal pedis and the posterior tib pulse to get your value for your ABI.
So do I do that math then?
You do the math.
Oh, Lordy.
That's not good.
I know.
Yeah.
I know.
I don't like
There's
that.
like division, calculations involved. It's tough. It's tough. And then you also have to hear, you have to hear the vessel, the changes in the vessel, to be able to understand if that vessel is monophasic, biphasic, or triphasic. And so there's just really a lot of clinical judgment going on in a manual ABI.
So that does sound intimidating.
A little bit. It's a lot. It's a lot.
Yeah.
Right.
So let's talk about automation.
Okay.
When we automate ABIs, we put 4 cuffs all at once on the patient. We press a button,
Love that.
Love the button.
Love the button.
No math.
No math, no math. And then after 3 minutes, the results print out, and we'll show you a result in a case study in a little bit.
And when you do an ABI, let's go back one more thing, because Lizzie may not have all the equipment, but you said you listened to it. Do we put a stethoscope on there? Because I've seen people do stethoscopes.
Right. No, we are using a handheld Doppler, and we are squeezing the cuff, and then we're using the Doppler to, when we release the cuff, we're hearing that blood flow come back in. The very first tick of that blood flow that comes back in is going to be your systolic pressure that you're going to use in your calculation.
So it's one at a time too. So
Yes.
that process
Yes.
has to take
Yes.
a clinic room like 20 minutes, I would think.
I sat through one one time with a customer in Boise, and it took her 45 minutes to do the 2 systolic pressures in the arms, 2 each ankle, and then she did the toes as well all together.
Oh,
so
goodness.
it was
Our turnover time is much quicker than that.
when they came out of the room, I said, "You need our automatic ABI. You
Yeah.
need our ABI machine." And so yeah, we had that great discussion.
Yeah. And so you and I were recently discussing this, and we talked about a lot of people do not do ABIs because of it's not compressible. It's not going to work anyway, so why do it?
I know.
So
That
can you tell us-
diabetic, let's talk about the diabetic population.
Yeah.
So non-compressible arteries are arteries that become inelastic because of the calcification of the artery and the peripheral arterial disease that's occurring. And so arteries that become hardened can't be squeezed, and so you never can cut off that blood flow to then release it back in and get that systolic beat that comes back in. So if you can't compress that artery, we need to have another solution for these patients at the point of care. We can't send every diabetic. The diabetes is rampant in the United States. We can't send every diabetic patient to the lab. It's again that bottleneck at the vascular lab, and they're short-staffed. It's just a big bottleneck. So a simple toe pressure device can just give you the value that you need to do your point of care, and then you're going to send that patient to the vascular lab, of course, for the workup. But to be able to compress and debride and place your camps at the bedside, you need that value.
Yeah, and I think too, like evaluating just what their waveform looks like so that you can kind of emphasize the priority to the vascular team. Like, is this routine? Is this stat? Like, how quickly do we need this? And also just that's something then for the patient to also learn and know, like, look, this is what it should look like.
Right.
And yours looks like this.
And yours does not look like. So yes, when we talk about the phasicity of the artery, we're talking about with a Doppler waveform, we're talking about monophasic, biphasic, or triphasic. And then with the PVR waveform, we're just talking about a sharp upstroke or a dampened waveform when we see without a dichrotic notch. That's sort of what we're looking for. And you really have to compare the waveform with the value. And we're going to talk about that in a second, why that's so important.
And we talk about the bottleneck. You know how many patients, Liz, on the outpatient side, we send for a vascular assessment because I'm in a new facility. We don't have access to this. And they come back and saying 6 weeks they waited, like you mentioned. And they say, well, it's not compressible, but there's no other test. So we're having to restart the wheel again.
I know.
So time is valuable.
I know.
Yeah.
It is really valuable.
Well, let's take a look at those 2 devices that you mentioned of the automated ABI device.
So this is our Dopplex ability. It has it measures ABIs like we talked about in 4 limbs simultaneously, and the test takes 3 minutes to perform. It all said and done, it's about 8 minutes with the patient. There is an 85%. I'm really proud of our Dopplex ability because there is an 85% accuracy compared to manual. The manual is obviously the gold standard, but it's so time consuming. We want the automated device to be as close as possible to the manual. And so we've done a lot of internal studies at Huntleigh that shows that our ability device, when compared to manual Dopplers, has an 85% accuracy. It's easy to use. It is automatic. We have an automatic printout of the results. it's just such a time saver.
That goes right into the EHR. So then that's shareable with like our vascular colleagues as well. And so it's something that's objective, which I also love.
We actually have a printout that you can take a picture and put it anywhere that you want it to go for your patient.
That's
so
really good.
It really makes it real easy to integrate into any EMR software.
I'm amazed. 8 minutes. Again, time is valuable. I time people when they do manual ABIs, and it's usually no less than 15 minutes. Yeah. And then you have to go back and, there's some prep and also some cleanup afterwards.
Right. Well, I think too, just taking the skill set out of it, because I know how well you listen and how well you hear. And so there might be an opportunity that you may not hear that first number where it needs to be.
Right.
She's not discriminating against age.
There's one more thing that we need to talk about with the Dopplex ability is that there are two different types of devices on the market. There's ones that perform oscillometric compression, and then there's ones that perform volume plethysmography. So oscillometric compressions or oscillometry is just basically when you get an automated blood pressure on your arm. In the arms, it's a very reliable device. It becomes less reliable when you're doing these compressions at the ankle. Yeah. Volume plethysmography is a different way to compress the limb, but and it's much more accurate. So you're going to get the lower, you're going to catch that lower ABI and that higher ABI, whereas the other devices don't catch the devices as low or high. Mm-hmm. They're much more inaccurate. And then we also have to talk about the CPT code. 93922 is the code for submitting for reimbursement with Medicare. And so, but the criteria for that is a device that performs volume plethysmography and a device that has a PVR visual waveform.
Oh, so that meets that. So you're good. Check, check.
Check, check.
Check. Another problem that I come across on the outpatient side, and by the way, Liz, you probably couldn't pronounce what you just said.
No.
But
awesome.
Yeah, exactly.
No.
But the other problem that I see is that we wanted to do toe pressures or TBIs as well, but we couldn't find a lot of devices available out there. But the other thing is, in my mind, if your arteries on an ABI is calcified, wouldn't something more distal be even more calcified?
Interestingly enough, the toes are less calcified than the major arteries. That data could be changing, and it depends on that patient population. And we do run into sometimes toes are calcified, and then you're going to send that patient to the vascular clinic. But those are less for sure than the ankle arteries.
Yeah. Is there additional options with the ability device for diabetics? Like, is there like add-ons, or how do you handle a diabetic patient versus like just a lower extremity wound patient that's non-diabetic? So
we have the separate kits. So the Dopplex Ability is our ABI device, and then we have the separate kit that you can purchase together. Very cost-effective, the most cost-effective on the market, honestly. And the separate kit comes with our Dopplex, with our DMX Doppler with the visual waveform. Okay. And then that's what you're going to be using to get your toe pressure. So you're going to see your waveforms. You're going to be able to evaluate your arteries at point of care. Before you even do that toe pressure, you're going to be able to know if that patient has a monophasic, biphasic, or triphasic waveform. You're going to know what to expect with this patient. The tools are invaluable for clinicians.
Mm-hmm. And I do have the product, by the way, and I love watching the waveform, because now we don't have to wait 6 weeks. We have it right there. And I can't tell you how many times I've seen an ABI that appears to be normal, but with a monophasic waveform. And so I have to ask questions.
You absolutely should. Yeah. That's always good.
So can you walk us through maybe like a couple examples of like patient cases?
Sure. So we have 2 quick case studies that we're going to highlight how automated ABI and toe pressures really change the course and the outcome of this patient. Okay, so here's our first case study. So here you see the results. This is our Dopplex Ability, and you see the results. This is the printout that you're going to get. You have the systolic pressures of all 4 limbs. You have the ABI value, and you have the waveform. This is really good information right at your fingertips. So in this case study, we have the ABI was 1.3, so slightly elevated. And so you just kind of wonder what's going on with that patient. But you can compare it to that PVR waveform, and the waveform is a nice sharp upstroke. It's got a good dichrotic notch.
Yeah.
That patient looks very normal.
We like that one.
We
It's
like
not
that
the-
one.
not
It is
that
not.
one.
It
Yeah.
is not. It is not monophasic. Thank goodness.
Yeah.
And so the PVR waveform is the thing that's going to make the difference.
Great.
In the second one, here we go. This is one that I see patients and I see clinicians who contact me all the time. How do I read this? Why is the ABI normal? What is going on with this patient? And so a lot of times patients can have like the ABI can be, I think of it as on a continuum. That artery isn't elastic or non-elastic. It's becoming elastic, it's becoming non-elastic, it's becoming hardened. And sometimes the ABI can look normal, but the PVR waveform is dampened and monophasic.
Yeah.
And that's when you are really it's flat and blunted. And so that's where you're really going to say, okay, we've got something going on with this patient. We need to send that patient to the vascular lab for a workup. And in our second case study, that's exactly what happened. That patient had to have a vascular procedure, and they had a successful bilateral angioplasty, and the patient had a really great result based on that point of care clinical findings.
Yeah. So not just the math numbers that we have to do, but also having
Reading the
that
waveform.
waveform and knowing, because often I feel like when I'm teaching walk nurses like how to do a manual ABI at the bedside, and I'm like telling them, okay, do you hear, is it biphasic? You know, like even listening to it, there's like, that is such a skill set that is not, so like having the like up, down, here's the notch is like nice to be able to have a visual. I mean, wound care people are visual anyway, so
Right.
it's really nice to have.
And there's I teach a lot of new wound care providers, and they have a really hard time hearing the changes in the arteries. And you know, the clinicians that have been doing this for 30 years can hear it in a heartbeat, but we have to have something that is educational for these new providers to learn.
Well, thank you so much for sharing this with us. I think this is going to be a game changer because point of care testing, I think, is exactly where we need to be in this world that's siloed and fragmented. We just need to do the patient-centric thing and get them those results because time is tissue, right?
Right. And thank you very much. And also, if you're looking to elevate your vascular assessment, consider integrating PVR technology into your workflow, because this solves a problem that we see a lot in our clinics. So thank you. And that's it for the Frank Lizzie Show. We're here at live studio at SAWC Spring 2025. Thank you for turning in. And also like, subscribe, and join the Frank Lizzie Show.
Yeah, thank you,
Thank
Kim.
you so much, Frank and Lizzie. I appreciate the opportunity.
Yeah,
Thank you.